Podcast is now starting. All attendees are in listen-only mode.
Okay, so it's 1 o'clock, so we might get started. Felicity, if you're ready.
Yep, I'm ready to go.
Great. Well, welcome everyone to the webinar today. My name's Miranda Cumston. I'm the Senior Program Manager at the Australian Clinical Trials Alliance. And this is the first in a series of webinars we're presenting over the coming month or so. I'm delighted to welcome my colleague Felicity Flack, who is the Manager Policy and Client Services for the Population Health Research Network, or PHRN, and they're co-presenting these webinars with us. PHRN is funded by NCRIS to fund national data linkage infrastructure. Felicity oversees the coordination of applications for cross-jurisdictional linked data projects, and she's also the chair of the Sir Charles Gairdner Hospital Human Research Ethics Committee and is writing a book on ethics, law and policy of linked data for research, which I can't wait to read that one myself, actually. And I also need to acknowledge the support that we've got from the Australian Research Data Commons, also funded by NCRIS, who are helping us with the webinar system today. So just a few housekeeping notes before we get started. Thanks again, everyone, for joining us. Just in case you didn't hear the announcement at the start, we are recording this webinar today and you will receive a copy of it afterwards. Just to let you know, you're all currently muted, so you won't be able to speak at the moment. If you do have a question for Felicity anytime throughout the process, there's a question box in your control panel and you can type questions in there. We'll take those written questions at the end and we'll have time then for Felicity to answer your questions and give you some further thoughts on the topic. And I think that's everything we need to know to keep going. But yeah, if you have any questions or difficulties during the session, you can also enter those in the question box and I will try and assist. So with that out of the way, thanks Felicity again for joining us today, and I'll hand over to you.
Thanks, Miranda. It's lovely to be here, and thank you to you all for joining us today. This series of webinars arose out of conversations within the ACTA reference group H, which is about innovative outcomes data, and also conversations between the Population Health Research Network and ACTA about the possibilities of clinical trialists understanding more about the possibilities of including linked data in their clinical trials designs. So hopefully these 4 webinars will give you a little taste of what's possible and how you can go about designing trials and using linked data in your clinical trials. So today we're going to focus on designing trials using linked data, but the whole webinar series, now that's interesting. There we go. So the objectives of the whole series of webinars, all 4 of them, is firstly to demonstrate the benefits of using linked data in clinical trials research, to assist you, the clinical trialists, to design clinical trials using linked data and apply for access to linked data, and also to introduce clinical trials researchers to the PHRN facilities and services available. So today we're going to talk about the design phase of using linked data in clinical trials. So by the end of today, I'm hoping that you'll be able to name some examples of administrative data collections that are available for linkage to clinical trials cohorts, that you'll also be able to identify the benefits and also the limitations of using linked administrative data in clinical trials, and describe the main factors to take into account when designing a clinical trial using linked administrative data. So I've got my fingers crossed that we're going to cover all of those things this afternoon. So first of all, let's think about what do we actually mean by administrative data. Well, administrative data is essentially any data that's collected in the course of providing a service. And that covers a broad range of types of data. This data is mostly collected for administrative and financial purposes, and it's also collected by a range of different groups, by state government, Commonwealth government, and also private entities. So things like birth records, midwives records, education data such as, say, the NAPLAN data collection, or even enrolment data at the state level, hospital admissions records, general practice records, disease registries like the cancer registries, notifiable diseases registries, these sorts of things, prescription data such as the PBS, the MBS data, Veterans Affairs, ageing data. So huge amounts of data are collected across the course of your lifetime by agencies who are providing services to you, essentially. And that's really what we mean by administrative data. So the qualities of administrative data are firstly that it's collected during service delivery. It's usually collected without consent. Nobody says or signs a consent form that says, yes, the government can collect my hospital admission data. The reason that the government can collect your hospital admission data is that it's mandated by statute. So all jurisdictions in Australia have a piece of legislation that requires, for example, that a record of every hospital admission must be sent to the State Health Department and kept in a collection. And governments use this administrative data for planning, monitoring and funding the services that they provide. It's usually at a population level so that every person who receives that particular service is included in that data collection, which also means that this data is historical data as well. So the classic example would be birth and death records, which are kept, some collections go back 200 years or more. You can get, if you're interested in genealogy, for example, you'll be well aware of birth, deaths and marriages records being available historically. And there's also a wide diversity of collections available, as I mentioned on the previous slide, lots of different areas, including education, human services and health, that are all administrative data collections. In contrast, clinical trials data, which I'm sure you're all very familiar with, is collected specifically for a clinical trial or a specific research project. And the decision about which variables are collected is how will they inform the analysis for that particular clinical trial. Clinical trials data, of course, is usually collected with consent, and sometimes that consent will include access to other information. For example, you might ask your clinical trials participants if it's okay if you contact their GP for additional information about them. I'm sure you're all familiar with that sort of thing. So administrative data can add substantially to what you can achieve in your clinical trial if it's linked to clinical trials data. So let's think about what are some of the benefits of linking administrative data to clinical trials data. Well, the main things are it can address a number of challenges that you face in clinical trials methodology. And the first is cost. The cost of collecting data prospectively over for large numbers of people over many years is substantial. And administrative data is routinely collected. And so it's already been collected and that collection has already been paid for. So even though there are costs associated with accessing administrative data for research, they're substantially less than the cost of a prospective data collection. The other thing is that because these are historic long-term data collections, they can be used for long-term follow-up over many years for things like dealing with loss to follow-up. And also helpful if you think there may be reporting or recall bias. These standard collections are usually standardized, cleaned, coded, so they can be quite helpful for that. And they're also really helpful for health economic analysis, because a lot of these records, for example, are about payments. So they do become very useful in health economic analysis. So there's a range of ways that linked data can be used to augment or replace data collections in clinical trials. And it's important to say that we're certainly not suggesting that linked data could be a complete replacement for a clinical trial. It's definitely a way to supplement or augment your data collection, and could be done in the following ways. We've already talked about long-term follow-up, but you definitely can follow up participants using linked administrative data for outcomes such as hospitalizations and deaths, or pharmaceutical use for a decade or more after the trial has been completed, for example. You can also use it because it's data that was collected before you recruited people into your trial. So you could use it to look at pre-recruitment hospitalisation, for example, as a measure of trajectory to care. So you can find out what happened to people prior to them enrolling in your clinical trial, which can be helpful for some trials. The other thing you can use it for is measuring healthcare or pharmaceutical use before and after an intervention, and that can be really helpful. And also measurement of primary and secondary endpoints. So things like death is a primary endpoint, but sometimes other secondary endpoints as well. So there are lots of really great things that you can do if you include linked data in your clinical trials. Including identification of eligible individuals or communities, which is potentially a really useful use of linked data, but in practice is probably quite difficult to do in Australia at the moment. But ideally, you would be able to find out at least how many eligible individuals meet the eligibility criteria in my trial in this particular jurisdiction. And again, as I mentioned before, economic analysis. And you also might like to think about it for sort of studies that you might do prior to starting a clinical trial, for example, looking at disease prevalence, comorbidities, those sorts of things. The other thing that is included in many administrative data collections are measures or status variables as far as ethnicity and race. For example, many administrative data collections will include Aboriginal and Torres Strait Islander status, and that also might be helpful for you in your clinical trials. And finally, something that I really don't know much about, but linked data can also be used in pragmatic or implementation clinical trials. And if you're interested in pragmatic or implementation clinical trials, APTA has a wealth of experience and information on this topic and have run a range of workshops and presentations. So perhaps go into the APTA website and look up all of the stuff that they've got available on pragmatic and implementation clinical trials. Okay, so I thought I'd give you a couple of examples of how linked data has actually been used in Australia to augment or supplement clinical trials. There's not been an enormous amount of use of linked administrative data in Australian clinical trials, but there are some really nice examples, and these two I think are quite good ones. So this first one, the aim of this study was to assess the long-term effects of treatment with statin therapy on all-cause mortality, cause-specific mortality, and cancer incidence. This study is a long-term follow-up of patients who participated in a double-blind placebo-controlled trial of pravastatin between 1990 and 1992. And the long-term follow-up included annual questionnaires and also linkage to administrative data. And this linkage to administrative data was used to determine cause-specific mortality and cancer incidence. And the linkage was done by linking to the national death registries in Australia and New Zealand and linkage to state-based cancer registries. And in this study, participants were followed for up to 16 years post-randomisation. So I encourage you to look up that publication to read more about the details about the methodology that they used and how they did the analysis. But that was a really nice example of long-term follow-up enabled through the use of linked data. This second example is about renal replacement therapy. And this study was conducted because the effect of differing renal replacement therapy modalities on long-term survival after acute kidney injury was unclear. So the aim of this trial was to prospectively examine the long-term outcomes and effect of renal replacement therapy dosing in patients with acute kidney injury. So all participants in a trial, which was called the Randomised Evaluation of Normal versus Augmented Levels of Renal Replacement Therapy, or the renal study, and who were also alive at 90 days post-randomisation, were then followed for an additional 3.5 to 4 years. All-cause mortality was determined by linkage to the state death registers, and information about maintenance dialysis was collected by linkage to the ANZ data registry. So this is a nice example of a combination of linking to a standard administrative data set and also a clinical registry. So lots of really nice things that you can do with linked data in your clinical trials. However, even though there are lots of benefits, you also need to understand what the limitations are to using linked data. As I mentioned before, linked data is collected specifically for usually administrative and financial purposes. It's not collected for use in research. So when the collections are established and the decisions about what variables are collected are made, they are not made with a research use in mind. So you need to keep that in mind always when you're designing your clinical trials and wanting to include linked data. So there's a couple of things that you really should take into consideration specifically when you're designing your trial. And the first is the limited data items. So the data items in any administrative data collection are related to the purpose of that collection. Therefore, they often don't include a range of data on confounders and risk factors. So things like height and weight, often not available in administrative data sets. But in general, they do permit perhaps more crude risk adjustment, for example, based on individual morbidities or comorbidities. But there's often a lack of sufficient clinical information to risk adjust for contemporary algorithms. However, when you're using both linked data and data collected for the clinical trial, hopefully you'll be able to collect what you need to do those more complex analysis. The other thing about administrative data collections is they are often of uncertain validity, or well, uncertain validity for the purpose to which you would like to put them, that is your clinical trial. So it's sometimes hard to know how good administrative data is at measuring your desired exposures or outcomes. And this can vary between different administrative data collections and different data items even within the data collection. So for example, differences in coding directives and practices over time can affect the validity of an administrative data collection for a particular exposure. And this is particularly a problem when administrative data collections are new and haven't been used for research much before, so people haven't tested the validity of them. So it's important to look for information about the validity of the data in the context that you want to use it, and sometimes you might actually have to do some validity studies yourself. Related to this is that administrative data sometimes has limited metadata. Some administrative data actually has excellent and very detailed metadata, and that will be of great use to you in your study design. But again, because it's not designed for research use, sometimes there's not a lot of information. It can even sometimes be difficult to find out exactly what data items or data variables are included in that data set. And certainly it can be difficult to find out more nuanced information about the nature of particular variables, how accurately they are recorded, and how reliable they might be, or how much missing data there might be, that sort of thing. So that's certainly a question you need to ask and look into when you're thinking about your study design. And then the fourth limitation that I wanted to bring to your attention today was about the linkage quality or the linkage error. And researchers will need some information about how data is going to be linked and therefore the quality of that linkage, so that you can make a decision about whether linkage is going to be suitable for your particular study, but also it may be you just need to adjust how you're going to do your analysis, taking into account what the linkage quality might be. There are a number of things that affect linkage quality. The first is the quality of the underlying data collections to be linked. If they're of high quality and very reliable, then the linkage quality will always be better. The other thing is the quantity of data items that are used to conduct the linkage. So the more data items you use to do the linkage, the higher the quality of linkage. So for example, if you do the linkage based on full name, address, sex, date of birth, it'll give you a much higher quality linkage than just linking on sex and full date of birth. The other thing that may affect a linkage quality is the exact linkage methods that are used. Most linkage units around the country at the moment will use a form of probabilistic linkage, which is usually a bit more higher quality than a deterministic linkage. A deterministic linkage is just when you take one variable, say a unique identifier number, or a series of variables, and you say if there's an exact match between those variables in two different data sets, then there's a link, and if there is not an exact match, then there's no link. The other thing that also will affect linkage quality is what the quality assurance processes are for linkage by the people who are conducting the linkage. So these are things that might be helpful to ask questions about when you're doing your research design. Okay, so in the next part of the seminar, I'm going to go through some steps one by one that you should start thinking about when you're starting to design your clinical trial. So the first question you should ask is the data I need available? Because if the data you need is not available, then there's no point in pursuing this any further. So let's think about an initial example where somebody's running a clinical trial in New South Wales and New South Wales only. And they're interested in linking, let's say, the admitted patient data collection to look at hospitalisations prior to enrolment. So the first thing to do is to go to the website of the New South Wales Data Linkage Unit, which is called CHRL, the Centre for Health Record Linkage, and look at their list of routinely linked data. And you can see on the right-hand side there the list of routinely collected data collections in New South Wales. And on the top left-hand side is the admitted patients data collection. So great news, there is routinely linked data available that you can use for your trial. It's worth mentioning also, sometimes data linkage units will have a second list of data collections, which they don't routinely link, but they have sometimes linked, or they have linked in the past. And the importance of knowing this is that routinely linked data will be available to you much more quickly than if a new linkage is required. So that's just something to keep in mind. But anyway, admitted patient data collection, definitely available in New South Wales. And the other helpful information that you can find on the Data Linkage Unit website is the years over which the data is linked. So you can see in New South Wales from July 2001 to September 2018 for public hospitals, and for private hospitals up until December 2017, which is another important question to ask: is private hospital data routinely linked? Because it isn't in all states, but in New South Wales, yes. So if you want to look at all hospitalisations in your clinical trials cohort, it would be possible to do. So once you've established that the data collection that you'd like to link to is available, it's routinely linked, and the years that you're interested in will be available, then you need to dive a bit deeper and look at what specific data variables are going to be available, and will they meet your needs for either exposure or outcome measures, and is there any more detailed metadata around the particular data collection. So in this case, you click through and you'll see that for the New South Wales admitted patient data collection, there's both a variable list and also a data dictionary, and you should go in and read those and check that they're going to meet your needs. Now, I imagine that many clinical trials are actually multi-site and occur in multiple jurisdictions, and this is what we call cross-jurisdiction data linkage. So if your trial falls into this category, you're going to have to do a little bit more work to find out if the data that you need is available. And a good starting point is to go to the PHRN website, and you can see the link there below on the slide, and go to our For Researchers section, which has some metadata around the routinely linked administrative data in every jurisdiction in Australia, including the Commonwealth. But in this case, we're looking for admitted patients, and you can see you can go in here and find that actually all jurisdictions in Australia link hospital admitted patients data, which is good news if you want to do a study including every state and territory. But importantly, when you want to do a cross-jurisdictional project, you're going to have to find out whether the data that you want available is available over the right time frame in all jurisdictions, and whether the variables you want to access are also available in each jurisdiction. So we provide some charts which give you a sort of bird's eye view of the availability timeframes for the different data collections. Again, you can see the link there on the slide. But on the right-hand side, you can see this is public hospital admitted patient data in all states and territories in Australia. And this chart shows you that in Western Australia, the admitted patient data collection is linked back to 1970, so they have a very extensive routinely linked data collection. In most of the other states and territories, it's a lot less than that, but most of them have about 10 years of data linked. So it's well worth sort of looking through that and having a think about whether the timeframes are going to work for you. The next question that you should think about when you start to design your clinical trial is, when will the administrative data be available? And you need to ask this question because most administrative data is not collected in real time. And there also is a lag between the data collection the linkage and the data available for analysis. And for some data collections, this lag can be up to 12 months. So this is going to be really important when thinking through your analysis timeframes and when you need data to be available. You'll need to take this into account when deciding whether this is going to work for your particular design. So make sure you remember to take this into consideration. And ask questions of your data linkage units about what the lag is likely to be. And then the next question you should ask is this administrative data fit for my purpose? And so you should definitely check whether the same variables and level of information is available in all jurisdictions. I think, for example, in the hospital administrative admitted patients data collections, because they're part of the national minimum data sets, they're more likely to be comparable amongst states, but other data collections can be quite variable in what's available in some states and not others. For example, mental health data collections tend to be a bit variable. So that's something to think about carefully. The other thing you might need to ask questions about is there might be a data variable that's actually collected in the data collection, but it may not be something that the states are willing to release for research. So, for example, some states may be happy to release full date of hospital admission and others may not. So you need to be careful that you can actually get access to the exact data variable that you want, or you might need to modify your analysis to base it on the minimum amount of data that you can get rather than hoping that you'll get all the detail from all jurisdictions. I mentioned this earlier, but checking about whether there's any validation data available is really important. Now, some data linkage units will publish or provide some, and some data custodians also will provide validation data, and definitely look at that if that's available. You definitely can get some of that from the Cheryl and New South Wales website. Researchers who have previously used the data collection may also have published something about a validation study or something about their experience of using that data collection. So you should try and find those out. It's also sometimes helpful just to talk to somebody who has used that data collection before and analysed it, and they might just be able to one-on-one give you some insight into using that data collection. Alternatively, you might decide that you need to conduct a validation study yourself. And I've just added a reference in there for a paper that might give you some ideas about how you might go about doing a validation study. The other resource that you might find helpful to look up are the record statements. There are two record statements, one for research involving pharmaceuticals and the other for all other research. And it's really just a checklist of all of the data and information that you will need to include in your final publication. But I always think it's really helpful to think about that at the beginning when you're in the design phase, so you make sure that you do collect all of the information that you're going to need when you finally publish your clinical trial. So the link's there, and that's well worth a look to have a check at the kind of information you might need to include in your publication, particularly about the linkage and how the linkage was done and that sort of thing, which you may, because you probably won't do the linkage yourself, you might need to collect information from your data linkage unit to include in your publication. The next thing to think about is your research team. And I highly recommend that you include a biostatistician or analyst with skills and experience in the analysis of administrative data in your team. Administrative data is different to analyse to your clinical trials data because of all of the things I've discussed earlier in the presentation, and it does require a lot of cleaning and formatting, and the way you go about analysing it can be a bit different. So if you can find somebody who's very experienced, you should definitely include them in your team. Of course, sometimes this isn't feasible. So if that's not possible, I suggest you get somebody or more than one person in your team to attend a training course. And there are a number of training courses held around Australia and also internationally. Two I've included here as examples are Introductory to Analysis of Linked Health Data at the University of Sydney and also the University of Western Australia. And all the people that I've spoken to that have attended these courses over the years, they're very well established courses and have been running for a long time now. Really highly recommend them and say they were really helpful. So definitely make sure you've got the right skills and experience in your research team. Consent, of course, is always an issue, and as clinical trialists, I expect that you'll know an awful lot about consent, but just a note to say that you will need to think about how consent is going to be managed. In most cases, I would assume that you're going to get consent for the use of linked data, but there may be some circumstances where you might be able to rely on a waiver of consent. So you really need to think about this early. Everything is much more likely to go smoothly if you thought about consent before you start the trial, and it's not an add-on or something you thought about halfway through or after the trial is complete. But I'm not going to talk much about consent today because we're going to do a whole webinar on ethical issues in webinar 3. So if this is something that particularly interests you, I encourage you to come in 2 weeks' time. The other thing that you should think through is when you will need the data linked. And this is going to depend on why you're using linked data in your clinical trial. But you might, for example, want your data linked at the completion of enrolment. For example, if you're interested in pre-enrolment hospitalisations, that might be the time at which you'd like to have your linked data. Commonly, you would access linked data at trial completion or potentially, years after trial completion if you're doing a really long-term follow-up. But you also might like to think about accessing linked data multiple times throughout a trial. For example, if you're running an adaptive trial, that might be something that you need to do, is to get linked data at multiple time points throughout the trial. You should think about the practicality of how many times and when you want access to the linked data. Of course, there are costs involved to every time you have data linked and data extracted for you. And there are also practicalities on your end about how you're going to handle the data and manage the analysis at multiple time points throughout the trial. So definitely take that into consideration. But make sure, whatever your choice is, that you clearly specify in your protocol the number of times that you're wanting linked data extractions. This will be really important because the workflow has to be built into the data linkage unit's workflow, and they need to know how many times they're going to have to do this work for you. And last but definitely not least, you need to think about data management early. Of course, you'll be well aware of building data management plans for your clinical trials, but you'll need to build in the nuances and differences of administrative data into that data management plan. And you'll also need to provide a detailed data management plan in your application for linked data. We're going to talk more about data management in webinar 3, but just to get you going, a really good starting point is to start with a data flow diagram, which is identify all the sources of data that you will be collecting data from over the course of your clinical trial, and where will that data be being transferred, analysed, moved, stored, and who will be accessing that data at the different time points along the trial. If you can kind of map all of that out, then it can make life a lot easier to build your data management plan. So I've just put some of the resources available that might help you in thinking through your design. Some metadata resources. So as I mentioned earlier, go and have a look at the PHRN website. There's some really helpful resources for researchers there around metadata across all jurisdictions. So it's more of a good starting point to see what's available in all the jurisdictions that you might like to be accessing data. I've also added their link to all of the Australian data linkage units. A nice ARDC resource which is about data management frameworks and plans, and some links to training courses that you might like to follow up on. And finally, I need to say thank you to the ACTA Reference Group H. They've all been really wonderful in giving us feedback on the design and content for the webinars. There are also some additional researchers who provided feedback on the webinar materials, so thank you very much to them. ARDC have been fabulous in providing the webinar platform for us and teaching us all how to use it, which has been great, and also to the PHRN and NCRIS who fund me in my position. That's good. So I think we can, if you do have any specific questions or want some more information, go and have a look at the PHR website, and that's my email address if you would like to ask me any questions. I'm happy to hear from you. So I think we'll finish there, and if anybody's got any questions, I'm more than happy to answer them.
Yeah, thanks, Felicity. That was really great. Just a reminder, if you do have any questions, in the questions section of your control panel, there's a box that you can type your question in, and we'll make sure it gets answered. While people are thinking and typing about questions, Felicity, I'm interested to know, I know PHRN has got you know, an overview of lots of different data sources, and you mentioned a few. Are there any other, can you give us an idea of the other kinds of data that might be lurking in there ready for a trial?
Sure. So most states and territories have things like admitted patients data, emergency department data, births, deaths, perinatal or the midwives data collections. Quite a few have ambulance, mental health data collections, those cancer registries, of course. Everybody has cancer registries linked. Some have notifiable diseases. Some have things like breast screen, some of the other cancer screening registries. And they're things that are sort of routinely linked. Different jurisdictions have, some of them have really large and broad data collections. So Western Australia and Victoria and South Australia also have quite a lot of non-health stuff, so into the education, child protection, more human services side of things as well. So yeah, there's actually quite a lot available. And of course, through the Commonwealth, MBS, PBS, the Australian Immunisation Register, another useful one, yeah, National Death Index, yeah.
I'm sure you could keep listing. That's a lot of data out there, is the short answer. No, that's great. Thank you. So we've got a couple of questions coming in. So we've got one from Rachel Morton, who's asking whether you can advise whether AIHW provides hospitalisation data for the whole country.
Well, the answer is yes and no. So currently, so you can apply to, well, there is a data set that the AHW are building at the moment, which is called NICE, and I always forget what it stands for, National Integrated Health Services something. I should know that better. That does not yet have all states and territories hospital data in it, and it's currently not available for researchers to access as far as I know. So I think the simple answer is today, no, but in the future, likely.
Okay, thank you. We've got another question from Damanan, who's asking, how do you handle data sets where the diagnosis codes don't have a clinical onset flag? Do you know if that data is usable, unusable, or does it depend on the trial?
Okay, so now I'm going to confess that I am not a data analyst, and that's a question for someone with more technical expertise than me. But if you send me through that question, I'm sure I can follow up and find an answer for that for you.
Thank you. Another question from Lisa. How difficult is it to obtain data retrospectively? That is, if the trial's been completed, but new questions could be answered with linkage, and she's particularly thinking of using hospital admissions data for that trajectory to care question.
So it depends a little bit on data custodian and ethics committee approaches. Theoretically, if you can demonstrate that the benefits of accessing that retrospective data without consent outweigh the risks to those individuals, then it's possible to do. But I do know that some ethics committees can be quite reticent about approving, particularly a clinical trial, when you did have the opportunity to ask people for consent in the first place. So it's a bit of a case-by-case thing. Theoretically possible if you've got a really good argument for overwhelming benefit and little risk.
Thanks. Alison's asking, is there an equivalent to Cheryl in other states?
Yes, there's one that services every single state and territory in Australia, and we'll tell you all about them next week. But yes.
Yeah, so next week's webinar will be specifically about accessing the data, so some of the more direct considerations around that. And Maheen is asking, overall, how do you see the quality of linked administrative data for clinical trials research?
Ooh. Again, I think it really depends what you want to use it for and which specific data collection you're using. And the size maybe of the trial as well. So, yeah, I don't think there's a simple answer to that. I think for some specific uses, it can be brilliant, but it is not the answer to everything.
Fair enough. Now, there's a couple of people who are asking about whether they'll be able to access the slides later on, and I think we have some good news about what they might be able to refer to after these webinar series, Felicity.
Sure. So, yeah, so as Miranda mentioned earlier, the videos will be available. I don't know how long it'll take us to edit them, but soon after the actual webinar. After all 4 of the webinars are complete, we're going to publish a guide that I presume we can send to everybody who's signed into a webinar. And that will include all the information that was in the webinars and a little bit of additional information and extra links and things as well.
That's great, thank you. So there'll be even more useful resources than summary slides, hopefully not too long after the webinar series. A couple of other questions. Jeremy is wondering if the National Hospital Morbidity Database is available for researchers, NHMD.
So it is, but it's not that. I don't think it's actually linked. So when the states send their data to the NMDS, they don't send it with an identifier on it. So you can access just that one, but I don't think it's easy to link it to a clinical trial cohort, for example.
Okay.
So you could use it for incidence calculations of a particular disease, yes.
Gotcha. Okay. And another question from Fanush. How long does it usually take to receive linked data after it's requested?
Well, we will talk about this a lot more next week, and the answer is it depends on the nature of your trial and the number of participants in your trial and how many new linkages and how many data collections and how the volume of data you're requesting, basically.
Sure. So just repeating, someone was inquiring about what that database was we referred to a minute ago, which was the National Hospital Morbidity Database, NHMD. Just repeating that. Yep. Great. So I think I'll just give people a couple of moments to type in any last questions. We've got a few people saying that they enjoyed the webinar and saying thank you, Felicity, which is very nice.
No, thank you for coming.
And so what I'm going to do, there's one more question coming in, which is from Anne. Is it more difficult with linked data in Indigenous populations?
Well, it's not any more difficult to link. It has the same level of difficulty to link. Of course, when you're doing research in Indigenous populations, you must use the Indigenous ethics guidelines. In some jurisdictions, that will mean that you have to go to specific Aboriginal and Torres Strait Islander ethics committees. But technically, no, I don't think so.
Okay, thanks. So it looks like we might have gotten through any of the questions, but please, people should feel free to get in touch with us after the webinar if they have further questions. I'm just going to, just bear with me for a moment, show you a bit more information about coming events and the additional webinars that Felicity has been referring to. Hopefully you can see that, which is some information about ACTA's conference, which is coming up in October, on the 2nd to the 5th of October, where these and lots of other issues relating to clinical trials will be discussed in detail. And also, if I can just get this to flick over, there we go. So there's the information about the coming webinar series. So there's 3 further webinars with PHRN, with Felicity and her colleagues. So one on accessing the data, one on ethical considerations, and one specifically talking about MBS and PBS data. And then we have another final webinar in the series, which is looking at a slightly different topic on studies within a trial, so methodological studies that can be nested within clinical trials. So do encourage you all to come along to those events and to join us for that webinar series. There's another final question about the cost of training courses and whether you have any further information about that, Felicity, or perhaps it's something people can...
No, sorry, not off the top of my head. Yeah, I think, look up, go direct to the providers and they can provide you with more information about cost and also dates and frequency of when those courses are provided.
Fantastic. Thank you so much. So again, then I think we'll, in the absence of any other further questions, we'll draw it to a close. And so I'm sure everyone is virtually joining me in thanking you very much, Felicity, for your time today. And
Pleasure.
Also to Susanna from ARDC, who's in the background making sure everything's running smoothly. Thank you very much. So thanks for joining us, and hopefully a lot of you will join us next week for the next exciting instalment of linked data and the PHRN. Thank you, everybody.
Okay, see you next week.
That was wonderful, ladies. Very well done. It should be fine. I'll just turn us all off. And Miranda, if you don't get the recording downloaded onto your computer, which it may or may not, it's, as I said, they've changed things, just let me know and I'll send you that.
Okay, thank you so much for your help today.
Not a problem.
Yes,
I will see you.
Susanna, that was great.
That's okay. I will see you ladies next week for the next one.
All right.
You will.
sign off
All
then.
right.
Thank you. Bye.
Okay.
Bye.
Thanks. Bye.
Bye.